Well, hello everybody and welcome to another episode of GUcast. This is Declan Murphy, urologist here at Peter Mac. Welcome back, Renu. How are you?
Good morning, Declan. I love getting people up at our surgical time of 6 a.m.
Yes, 6 a.m. is fine for us. We like getting up at 6 a.m. But some of our guests, well, one of our guests doesn't normally get up at 6 a.m. with the same enthusiasm, does she?
Yeah, but she's here with the same enthusiasm.
I know.
So
She
it's
certainly
good.
looks enthusiastic this morning. We'll get to her in a tick. And it's also great to welcome back into the studio friend of the podcast, Professor Daniel Moon, a consultant urologist here at Peter Mac as well. Hello, Daniel.
Morning,
G'day,
Dan.
Dick. Renu, wonderful to be back.
Yes.
Amazing setup now. We've got the video going as well. So
Yes.
it's fully professional. Well done.
That's right. Well, apparently that's the way to do your podcast nowadays. It's hard, it's hard enough to do the audio, but now everyone wants to watch you on YouTube as well, apparently. So, so this is on YouTube as well. Just a bit of fun for us, but apparently people like that, and it does give people an extra platform. So thank you to everybody for your comments on the YouTube side as well. So this morning we're going to talk about the primary study, Daniel, isn't that right?
Absolutely.
Yeah.
It's groundbreaking. I'm very excited to see it finally come to fruition. It's been years of work, particularly from Louise, who's one of our guests. I'll let you introduce Louise.
Yeah, exactly. So that's our topic this morning. We're going to talk about the primary study, which was published in European Urology this week, led by our friend and collaborator, Professor Louise Emmett in Sydney. So let's go and welcome Louise back to GUcast. She's been on our webinars before, so it's great to have you back on GUcast, Louise. Good morning in Sydney.
Morning,
Good
Louise.
morning, and thanks so much for having me.
Yes, and welcome back, Professor Louise Emmett, nuclear medicine physician at St Vincent in Sydney. We collaborate a lot with Louise, and she's PI on the primary study and first author of this paper, which we're going to talk about this morning. And also on our screen, for those of you watching on YouTube, it's another friend of the podcast, actually, isn't it? Yes.
Absolutely.
Professor Anwar Padhani joining us from London. It's evening time in London. Anwar, welcome back. He's about to go to bed.
Nighttime, Declan.
Nighttime even. Oh gosh, it is quite late. Thank you for indulging us.
Thank you very much for the invitation.
Anwar Padhani, radiologist, specialising in oncology. Anwar is a big key opinion leader in MR and has a lot of interest in PSMA PET CT. His interest is in urologic oncology, but he's very, very well known for his views in prostate cancer. So it's great to have Anwar back on the podcast to talk about this interesting paper, primary. And we'll put links as usual in the show notes and so on. But before we ask Louise to talk us through the paper a little bit, I suppose this topic is of interest to us, Renu, because we have a lot of enthusiasm for the role of MRI in early detection. This is an early detection population we're talking about, isn't it?
That's right. I mean, we talk about how much we love talking about MRI and PSMA PET. Today we get to talk about both.
That's true.
Potentially taking precision medicine to another level. So it's great to discuss this.
It's true. And here in Australia, MRI has certainly become a standard of care for patients with suspicion of prostate cancer. We've very much followed the precision promise type paradigm. We've talked about MRI a lot on the podcast. And here in Australia, MRI is reimbursed in this indication. So there are no barriers. So therefore, for the last 4 or 5 years, patients with a suspicion of prostate cancer have all had an MRI prior to consideration of a biopsy. And very often they don't have a biopsy if there are no red flags.
Yeah, and I think, like you said, it's become standard of care. And with the combination of MRI and transperineal biopsies, we've really streamlined that approach of diagnosing prostate cancer.
But Daniel, MRI is not perfect, is it? So and we all know that, and you can see that around the world because despite high quality data like Precision and other papers showing the value of MRI for identifying lesions and targeting, it's not perfect, is it?
No, absolutely. But I feel in Australia we have really embraced this imaging as much as any country in the world. As you say, we have the reimbursement for it. We've very rapidly adopted and utilised it for all patients suspected of prostate cancer or on surveillance for prostate cancer. But in doing so, we do realise that a few slip through the cracks. It's not perfect. There are somewhere around the 1 in 5 mark where the cancers, for whatever reason, are MRI negative, or we have these rising PSAs and negative biopsies and negative MRIs, and we're still scratching our heads wondering. And so we're looking at field saying, what's next? How can we make our diagnostic process or surveillance process even better and enter primary?
Enter primary, and there's the great segue, isn't it? So, and of course, here in Australia, we have huge enthusiasm for PSMA PET. We've had widespread access to this as well, haven't we, for the past 7 years, really? And we've published a lot of data about PSMA PET, but predominantly in the staging situation, either staging newly diagnosed high risk or unfavorable intermediate risk, or for biochemical recurrence, or indeed for the evaluation of metastatic patients, especially as they progress. But what about early detection, Louise? So over to you. Tell us about the primary study.
Right. So, well, firstly, the primary study was a great collaboration between, three cities in Australia. So, immensely grateful to everyone who was involved. And it's a prospective multi-centre imaging trial, essentially, where we took patients who were having an MRI. They had suspected prostate cancer. We knew they were going to be going for radical prostatectomy, and we slotted a PSMA PET in there. And I guess the question was, why would we do that? We'd just done a pilot study. PSMA itself is very interesting. The receptor is interesting. It actually gets more receptor on the cell with the more aggressive cancers. So for me, something that we'd done earlier was, can you differentiate pattern 3 disease on histopathology from pattern 4? And a small pilot that we'd done in 56 men showed that you could actually really nicely differentiate pattern 3 from pattern 4 with PSMA. So then the next question obviously was, could we use that in the diagnostic setting to improve diagnosis and pick up those patients who had MRI negative disease and find out if it was positive, and could we actually detect more disease on those patients who had 4 or 5, or how was it valuable? So that's really the whole tenet of primary. So we slotted a pelvic only. We didn't do a whole body on these patients because they didn't need the radiation dose. They hadn't yet been diagnosed with prostate cancer, so it gave a very low dose radiation. It was less than 4 millisieverts to these patients. And we just slotted that in between the MRI and the biopsy for 291 patients, essentially. So very, very simple trial, and it went very, very smoothly. And I think the findings were very interesting.
So these are men, they're biopsy naive. They just have a little bit of suspicion of prostate cancer. And I think it's important to say that unlike precision in studies like that, Dan, these were patients that had still a persisting clinical suspicion. Okay, some of them had PI-RADS 4 or 5 lesions, we're going to have a biopsy, but it also included like PI-RADS 2, 3 patients who had a bit of a red flag. There's a reason why they were scheduled for a biopsy. So the inclusion criteria was, had an MRI, but definitely were having a biopsy. So, the 68-year-old guy with the PSA of 4 and a PI-RADS 2 lesion is not in this study. But the one who's got a PSA density is worrying, or a younger patient, and factors like this.
That's right. So it included those patients in whom the MRI had suggested there was prostate cancer present, but it also included those patients in whom the MRI looked okay, but there was a concerning feature. There was a red flag, as you say, a family history, a rising PSA, something palpable. And what it gave as a clinician, it meant that we then went to a biopsy with both a PET scan map of any hotspots or abnormality within the prostate and an MR map. And we felt really very spoilt to be able to do that and target quite precisely any areas of abnormality on both MR and PET. And the findings, as Louise will expand upon, were really interesting because we had a whole mix of patients in whom the MRI and the PET both found clearly an abnormality. We had patients where the MRI was positive but the PET scan didn't pick it up, and vice versa. So it seemed that if a patient had cancer, one of those modalities would definitely pick it up. And what that meant on the flip side was that if you had patients that were both MR negative and PET negative, then the chance of cancer being found was exceptionally low. And that leads us to the next iteration of this study, which we'll go on to, which is primary 2. But let's be interested to hear Louise's summary of our findings.
Yeah, so let's hear about the results then. What was the additive value of PSMA PET for this population?
Well, our primary endpoint was negative predictive value. And with MRI, our negative predictive value was 72%. When we looked at PSMA on its own, it was 80%. And when we looked at the two together, it was 91%. So we had this very significant improvement in negative predictive value, and similarly with sensitivity. MRI sensitivity, 83%, PSMA sensitivity, 90%, but when we put the two together, we got to 97% sensitivity. So that meant that there were just a very few men in whom significant malignancy was not detected. So that was 3% for the combination of PSMA plus MRI did not have their significant malignancy, as in an ISUP 2 or greater, while 17% of men were missed on MRI. So it was a significant improvement in detection of significant malignancy. In fact, what's interesting about the results is when I really, at the very beginning of this trial, what I thought we were going to find was an improvement in positive predictive value. I thought positive predictive value was going to be so much better. And in fact, they were almost identical, no significant difference between the two. So great improvement in sensitivity. And that was really strongest when you looked at those patients who had, obviously, those patients who had PI-RADS2. And one of the things I think is a little bit unusual about this study was that the PI-RADS2 patients had quite a high significant or malignancy. 28% of them actually had significant malignancy. Which is a high percentage if you look at other studies. But that's because we'd really triaged these patients. Yeah. We hadn't included the low-risk PI-RADS2s. We hadn't included PI-RADS1s. So it was really PI-RADS2s with high risk. And so that's why I think this study is really nice, because, you know, those guys who do have those red flags, who have a negative MRI, and you do a PSMA PET, the pickup rate was 90% for all significant malignancy in those groups. And similarly with the PI-RADS3, you know, you might not have a target on a PI-RADS3, but we had targets on the PSMA PET for biopsy. And the pickup rate was also 90% in PI-RADS3.
Louise, can I delve into that a little bit and just remind people listening who may not be familiar with how PET scanning is working? Basically, it gives us, if you ever look at the radar map of the weather in Melbourne, it gives us the areas of high rainfall being red to the low rainfall being green. And that's what we're looking at in a PET scan. I try to explain to patients. And obviously in a prostate, we're looking for that the thunderstorms and to show us where the nasty cancers are. But the point, what I'm trying to get to is you had to really write the book again or decide what you felt was a significant lesion in a prostate. So on PET scanning, you had to decide what was positive, because you have to draw a line at what we call the SUV max, which is how avid or bright something is lighting up on a PET scan. You had to decide what you call positive, and that was a big. Makes a big difference as to where you draw that line, as to what your sensitivity and specificity of this study is. So, explain how you came up upon the number that you used to call the positive scan.
Yeah, that was a really tricky part of this trial in the beginning, because of course we didn't have any evidence on which we could base. We had done an ROC curve in our original study that showed a cutoff of FC max that we could use. So we went a little bit below that, but we actually did an interim analysis in this study where we did an interim ROC curve analysis of the PETs, and that gave us the base at which we should use. So that's where, and in fact, that has been very stable. Once we went from 100 patients to 300 patients, the ROC curve with an SUV max of 4 was what we used as a base. So we, you know, nuclear medicine physicians, we love to dial everything up, and we call even, you know, minor wind disturbances. So we had to, you know, be really firm with everyone. No, you're not allowed to call that. And we used an SUV max 4 as a cutoff, and then patterns of activity beyond that. So that's actually how we reported, was through the interim analysis. And that was, in the end, worked out an extremely good way of designing the trial. In some way, you know, it's interesting when you start these new modalities and you're trying to derive what you should call what's positive, what's negative. You're really picking something out of the air. But that's how we did it. We are going to expand on that further, actually. Something that PI-RADS does really well and that we don't do in PSMA PET is define the transitional zone and the peripheral zone. And that's the next thing for us, is can we on PSMA PET actually improve our diagnostic capability even more by looking at the regions of the prostate and whether we report by region as well as by intensity, which is not something that we did in the primary trial.
Okay, bunch of great stuff to talk about, and just a comment on the transition zone. I mean, MRI just shows this beautifully in normally the transition zone and peripheral zone and all that. So I take home from this a couple of things. First of all, we should always do a PSMA PET prior to a biopsy in all patients. Or number two, maybe we should just replace PSMA.
No more MRIs.
No more MRIs, just do PSMA PET. But we'll go to Professor Padani, who's on the PI-RADS committee among many of his other.
He's waving his hands.
He's waving his hands furiously. And we'll ask Anwar for your reaction on this. Presume this is the way forward, just PET for everybody, or maybe drop the MR and just do PET. There was a lot of eyebrow raising for those of you not listening or not watching on YouTube. But yeah, shoot, Anwar, and we're very interested in hearing your thoughts.
I mean, I have to say I really like this study. There's a few things. I mean, the few comments that I had, and maybe I'll start with a question for Louise. When you did your ROC curve and you picked the value 4 on your first 50 cases, which you said was very stable afterwards, was that to define, was it just the optimal point of the ROC curve, or were you trying to maximize sensitivity or specificity? And you see, that could have altered some of your results.
Yeah, so what we did, we actually got 4 before. The reason I chose 4 was because the other levels were unacceptable. So we work in full, I don't like decimal points when we come to SUV maxes. You have to work in whole numbers. And so we did 3, and the specificity of 3 was 11%. Right, no. So then I did 5. The sensitivity of 5 was 75%. No. So then I did 4, and sensitivity of 4 had a 92% sensitivity, and the specificity was 45% or similar. So it really was like a natural fit.
So like normal MRI, yes, sensitivity is about 90%, specificity is about 50%.
Yeah, very similar. And so it was just unacceptable, any of the others. And then I refused to go to a decimal point because nuclear medicine physicians don't like intensity scores anyway. So to go to a decimal point on an intensity score would be laughable.
Pseudoscience.
Yeah.
Louise,
so what else, Anwar? I know Anwar's got a bunch of other things to say.
That was the first thing. I thought the limitations was actually a very interesting part of the paper, because I think it kind of laid it out. I mean, when I looked at I was looking at the negative predictive value for pyrides too, and I thought, what? It should be 12%. Sorry, 90% the negative predictive value, and this was like, and there were lots of cancers, pyrides too. But as you explained, you enrich this population. Yeah. So, it was a negative MRI, but it was a high clinical suspicion, high PSA density, family history, et cetera, et cetera. So I think it's perfectly reasonable, but I think that the conclusion has to be predicated on that population. So, say we will replace PSMA PET CT for all presenters to MRI. I mean, clearly that doesn't work. I mean, it might work, but it clearly doesn't work. The other, as in passing, remember there's 2 roles of MRI here. One of the roles of MRI is to say, there's the lesion. And the other one is to use the MRI diffusion biopsy and then say, there's the target, and there's a 3 millimeter lesion there, or there's the 5 millimeter lesion there. And, clearly that's not possible to do with a PET scan. But I mean, aside from that. So one was the higher risk prevalence in this population was 56%. The Cochrane analysis said it was about 30%. So it is almost 1.7, 1.8 times what you would expect as a background population, but with those caveats. But I think the result is really interesting, and it's corroborated by another study that's just been published in Radiology, which seems to suggest that, in fact, the biggest role for this technique is going to be in the high-risk negative MRIs,
yes,
and the intermediate risk PIRADS 3 cases. Now, PIRADS 3 cases, I just did a recent literature survey. PIRADS 3 occurs in round about 20% of people who present for the first time, right? So that's 1 in 5 men who are presenting will have a PIRADS 3. Okay, so these people are a real challenge. And if PSMA is going to get in there and help to triage that apart, that's great, because actually that will be helpful, because we actually need improvement in that area, because, the PPV is probably only 20% in that area. So there it really helps, but there's competition, right? The competition is cheaper, right? PSA density, for example, that can help triage that PIRADS 3 case out. AI looks like it'll be quite useful. Whether AI will completely dissect it out, I'm doubtful, but it's possible. Some other blood tests might do that, like the Stockholm 3 test, for example, has been shown to do that. Risk calculators, an MDT review a straightforward biopsy will do it, right? So those are all the other competitors for that PIRADS 3 space. So that's what PSMA is going to be up against. And then you're going to have to say, well, okay, then what is going to be the role of PSMA PET in that area? But I think it is there. But again, and I thought there were other patients in whom this test could really be very good. I thought, so, the rising PSA on somebody who is who's a PIRADS 2, right? He's on a safety net and his PSA continues to rise. Perfect. There's a nice example. Or a PIRADS 4 and a 5 with a negative or non-explanatory biopsy. Perfect. So I can think of 4 or 5 groups where the PSMA PET would really be very helpful. And I really like that figure you put in the appendix, just to show the correlation between Gleason score and PSMA activity. I thought it was a great graph. I thought that should have been right there in the middle of the paper, or you could have published it in another paper.
Aha, funny he says that, isn't it? Look, fantastic comments, Anwar. A bunch to talk about there. So what about the PIRADS 3s, Renu? What are your thoughts on that? Because I think Anwar's honed in on exactly what us urologists are interested in, or concerns we have about an MRI in these PIRADS 3 patients.
Yeah, so I mean, Anwar raised some very good points, and it's that the PSMA PET scan in this kind of setting can be very useful in certain groups of patients. Those patients who have kind of got those high-risk features on MRI. Maybe in another setting you would avoid a biopsy in them. So with that combination of PSMA PET and MRI, you really increase the precision of diagnosis in these patients while avoiding unnecessary biopsies. But also those patients where you really are not concerned enough to think about a biopsy based on their MRI, but maybe that PET scan will pick up something concerning so that we don't miss a clinically significant cancer.
And that's the way clinical practice tends to be around here, Dan. It has been for a while, but some of those subgroups that Anwar mentioned, it's going to be hard to design a big trial for that. So we sometimes say PSMA PET can be useful for when something's not quite right. As he said, those classic examples of the rising PSA, maybe after a negative biopsy, blah, blah, blah. And we use it all the time, but we'll never have a trial to deal with that. But the PIRADS 3s is a very big population, the 2-3s with a persistent clinical suspicion. So is that where this is likely to go to, or is that where the next research will go?
There are so many applications of this, and I put in nearly 100 patients into this trial, so I feel like I've seen every permutation and combination of PET, MRI, and biopsy finding. And there are so many possibilities here. Firstly, the thing about PIRADS 3 as well is that, and I may be able to comment on this further, but there's also a big variability between community MRIs and done in different centres by different radiologists, and a negative MRI may not be a negative MRI. And so part of this is also to, it's like a second opinion, if you like, on someone who you're not sure about the scan. As urologist, I can't pick up a difficult to see lesion in a transition zone on MRI in only one of the diffusion images, for example. So having a PET scan that lights up something to say, yes, this is something to be worried about versus no, this patient could avoid a biopsy is really critical. And the next extrapolation of this is, what about the men on active surveillance who have PSAs that are creeping up, their MRI is still PIRADS 2, they had a biopsy a year ago that was fine, but are we missing something? And a PET scan, if we can show that it gives you another opinion and another way to find cancer that other modalities may have missed, then that's another very big population that we could utilise this in.
So the enthusiasm.
One of the things I would say, one of the things I would say is that, when you say a urologist can't pick up a subtle lesion in the transition zone, well, that is true. But, an AI will probably
just to be clear.
We can with a needle.
And I will show you, and as I said, shortly I'm going to put something on YouTube that actually shows a bunch of PIRADS 3 cases where the AI is actually showing these things. So, and there's a big red blob, and that's not PSMA. That's just the AI saying, look here.
We should do a showdown at noon, Anwar.
But the important thing is that the best that an AI can do is be as good as an average radiologist. Remember that. So an AI is never going to be the top radiologist. The AI can only be as good as the best radiologist that there is. So it's like a radiologist in your pocket, but it doesn't give you that, that 10% increase in AUC. Every single paper is showing that it decreases variability, but it doesn't give you that AUC that goes up by 0.1, on your ROC curve. That's a step change. And for a step change, I think PSMA PET will do that in the PIRADS 3 cases. And that brings up that curve on the left-hand side.
To enough.
And that's why I think it's really useful.
And to enough certainty that those men who have a PIRADS 3 and a negative PET don't need to have a biopsy?
Well, I would have thought so. I mean, looking at this data.
So that's really interesting because, of course, Louise, that's this is a big population. Okay, they all had a clinical suspicion, so there's a bit of enrichment in there. But I was kidding, obviously, when I said clearly all of this population should have a PET scan. So where do you go forward? What are going to be the next steps in exploring the value of PSMA PET in this early detection population? Because I think we'd all agree you've shown there's going to be some value somewhere. That's I think what Anwar's been coning down on. So what's next?
Me?
Yeah.
You, Louise.
Yeah.
So look, I think I completely agree with Anwar. I think that the high-risk 2s and the PIRADS 3s are the group that we really highlighted where you get the best bang in terms of improved detection and improved accuracy. And I definitely think that's the place where we should hone down. And well, we are, aren't we, Declan? Is that what we're doing?
Yeah, well, that's what I was hoping you and Dan can have a talk about. So where you're going next? You're about to open.
As we can talk about primary 2.
Yep.
And so Anwar, what happened was, once we got all this data, it's like, what can we do with this? How is it really useful? And we had a very intense conversation over a series of months with the multidisciplinary team about how we should do this. And in the end, we have honed down into the high-risk PIRADS 2s and the PIRADS 3s. And we're starting a randomized trial looking at PSMA MRI versus MRI alone in that group to see whether we've got good value add. And then we've taken it one slightly more scary step further, which is to do just targeted biopsy in the PSMA MRI group versus template biopsy in the MRI targeted group as a non-inferiority trial. With primary endpoint being non-inferiority and reduction in biopsy. So if a patient does have an SU max less than 4 on the PSMA MRI arm, they don't get biopsy. So we estimated that was 38% of the PIRADS 2s, 3s on our trial would not require a biopsy, and that's the plan in the primary 2 trial. So I think at this stage, the power calculation is for 660 men to be randomized. And half of those men will get a pelvic PSMA PET with targeted biopsy.
And then, so it's both so remember, and it'll be very specified. Unlike this, it was clinical hunch for who goes into the trial. With this, it's going to be pre-specified risk features. So it's not just a straightforward PIRADS 2, 3. There's a clinical suspicion based on a number of parameters like PSA density and so on. Yep. And so if I understand, then the 2 aims we have are, number 1, you'll find hopefully many of these lesions that are not well characterized on the PIRADS 2, 3. You'll have a lesion. But second, if there's nothing, so it's kind of like almost a double negative scan. It's a de-escalation trial, essentially, because they don't get a biopsy. So you'll decrease the clinically insignificance and so on.
This trial is really exciting because we're putting the money where our mouth is when we're talking about the benefits of PET scanning and picking exactly that population that Anwar immediately honed in on. So if this plays out as we expect it to, in the group that we think there's a suspicion, it's PSA density, rising PSA, family history, something is not right, that there's a suspicion of cancer, but the MRI has given us a negative or equivocal value. The addition of a PET, if it plays out as we think it will reduce the number of men who need biopsies, because if a PET and MRI are negative, we're confident enough to say they don't need a biopsy. It will reduce the number of biopsies those men who are biopsied get, because we're just doing targeted, not template biopsies, and therefore we should pick up the same amount of significant cancer. But the third benefit is that because we're not doing template biopsies on all these men, we will have less diagnosis of what we would call the clinically insignificant cancers. So that low-grade, low-risk prostate cancer that we really don't want to, it's not a threat, we don't want to find it. It often causes a lot of anxiety, harm, over investigation. That should be reduced. And so they're really the 3 big endpoints we're looking at in this trial, and we're very excited to roll it out in the next few months, I hope.
Yeah, what do you think, Anwar? Is that a sensible way to go forward?
Yeah, I mean, that's right. I mean, I think that's a really good idea. So we know, for example, if you have a PIRADS 2 with a PSA density of 0.2 and above, 20% will have clinically significant cancer. So if you can reduce Templar biopsies in that group, by half, that's, I mean, I can provide you the figures to know what that will be. We know that if you have a PIRADS 3 and your PSA density is greater than 0.1, 70% don't have a clinically significant cancer. We've got the data on that. So if you can reduce that lot by a half, that is a win.
Yeah.
That's a win-win. So that's exactly the same group. But I was just thinking, there's this group of patients with PIRADS 4 and 5 who have a negative or non-explanatory histology. Now, I don't know if you can roll that into this. I probably not. That might need a separate trial. The other group that you might want to think about are these people who you're surveying. You send them off into the community, and then they come back and their PSA is going up. And maybe, I guess they will roll into this trial because they've had a rise in PSA in the community. I guess they could easily go into this particular trial as well.
What about, do you think, if you had a patient in the PIRADS 4 or 5 group who had a strongly positive PET, do you think they need a biopsy?
Yes. I mean, the issue is always the tissue. I know. I read in the paper that if there's 100% specificity, right? If you have a double positive, but there's a difference between grade group 3 and a grade group 5. Yes, I mean, even in terms of prognosis, we know that, right? So, yes, they have cancer, but how long have I got to live, doc? When that question comes up, you're going to go, well, I don't know. I never biopsied you, so that'll be an issue.
Well, it's funny you say that, and we've talked. There's a separate piece coming talking about the double positives and posing that question. Gosh, could you possibly avoid a biopsy and go straight to treatment? And I was on a webinar with some friends in China the other night, as you often do, talking about these things. I was presenting on this topic, and I was asked that question. I was asked a question exactly like this: how many radical prostatectomies have you done on the patients who were double positive? And I said, well, none, obviously, but it's a very interesting topic, and we're going to write about it. He said, I've done 32. Professor Young in Tianjin, and they have a paper about to go in, Yeah, I've done 32.
And what were the results?
We'll see.
Yeah, I guess.
Yes, but Anwar, we've been taking kidneys out on the strength of CT scans for years. And at least 1 in 4 up to 1 in 8, even large tumours or oncocytomas or benign. We take testicular cancers out on the strength of an ultrasound alone.
He's speechless. It's always hard to draw the parallels because prostate cancer is so controversial.
Yeah,
the
that's
overtreatment
right.
and also nerve sparing or focal treatment. There's all sorts of
and we don't do active
why.
surveillance for those other cancers.
Yeah.
Louise, can I ask? Primary was really in the early diagnosis setting. Because you alluded to the fact that PSMA PET has the ability maybe to distinguish between aggressive and non-aggressive cancers. What do you think its role would be in an active surveillance setting going forward?
So look, I think it's definitely got a role in active surveillance because it's that transition from 3 to 4 that I think it's actually tracking, and it's also volume. So increased volume, you can track that too. I do think though that you need to be able to watch the change, just like you do with MR. It's the change probably that's going to be important in active surveillance, not just a single time point. Because while we were very good at looking at clinically significant prostate cancer on primary trial, I'm not sure that we can differentiate between high volume and low volume, but can we get that very subtle gradations just with one PET scan? So, I think it'd be very interesting to see what happens in active surveillance. And I do think that there are some patients in active surveillance who struggle, with MRI struggling. And so once again, I think it will have a role. We need to define what that is.
Yep.
Yeah, I mean, but for a lot of listeners out there, Dan, this is all madness. This is the madness of unfettered access to PSMA PET. Remembering, and many listeners out there will be saying, well, this is a $7,000 scan that I can't get, and it's ridiculous. You just because you have easy access and you have affordable PET. We'll do these academic studies, but it might not change practice ever. But I think the primary 2 study is very interesting, because out there a lot of people will still do a prostate biopsy for the PIRADS 2-3 and find the insignificant cancer, maybe find the odd significant one, and that's why there's quite a bit of pushback, especially in the US still, on using how much faith we put in MR. So I think the primary 2 may have more widespread applicability than all the other stuff we do here, because we have such access to PSMA PET.
I think for that reason we have the responsibility to validate this scan, because at the moment it is being done really ad hoc with no proper algorithm or science behind it at times. So we have the perfect opportunity to test how good it is and put it in the right setting and show where it's best used.
Fantastic.
But I think that's important, because if you're talking, I mean, we are lucky enough to have such liberal access to PSMA PET, but if you're talking to a department that has to be very selective about doing PSMA PET, but can still get access to PSMA PET, based on this trial, who would you recommend gets it?
At the moment?
At the moment.
Yeah, in finishing up, Louise, is there any point doing a PSMA PET in a PIRADS 4-5?
Anwar.
I would say biochemical recurrence to be great for that.
No, I do mean in the early diagnosis.
A whole other
setting.
podcast.
That's right. Doses a week. So.
No question about biochemical recurrence, and since the ProPSMA study, no question about staging.
Yes.
For prostate cancer. Look, I do think the PIRADS 2-3, it's you're high risk. You're worried. The MR's negative. You don't know where to target it.
Yeah.
It's lovely. And obviously primary 2 will prove that. I also think that if we've got more certainty in the PIRADS 4-5 and we can improve diagnosis in the 2-3, where does this leave PIRADS? And in the future, maybe we can we need to incorporate somehow PSMA into PIRADS in a way that helps us know how to use it too.
So if you're feeling uncertainty after an MRI, get a PSMA PET.
So look, congratulations again, Louise, and all the collaborators on this study. Dan, you were the biggest recruiter, and we put a lot of patients in here. And a final comment on that, because all these patients obviously had 2 scans, and they found the PET scan really easy, Anwar, because here we do multi-parametric MRI with sagittals, and it's like 34 minutes in the scanner a lot of the time, versus quick 10 minutes in and out of a PET CT. So when they compared, like my patients loved it, I must say.
Declan, it was 3 minutes.
3 minutes. 3 minutes in the scanner. 1 bed stop.
There you go.
It's hard to argue against. I had a tiny bit of radiation, but 3 minute scan. That's the way I'll be having mine. I've had my MR of my prostate course already, but when I'm due my next one, I'm going to have a 3 minute PET scan as well, I think, Dan. So congratulations, and the next way forward, I think, is very interesting and exciting indeed, and we really look forward to that. And Anwar, thanks very much for all your valuable input on this, and we will put in the show notes links out to Anwar's YouTube channel, which he very generously puts these amazing presentations up there very regularly. We'll tweet it out with the link to this program, and we consume yours very regularly. They're totally fantastic. And also a shout out to the International Cancer Imaging Society, ICIS, will put a link in there as well, who you're a trustee and you've been past chair, I think, of that board, but they are very, very interested in this topic, imaging in cancer, and clearly they look across all modalities, conventional and nuke med. So ICIS, another great resource, and we'll put out links to that. That's all we have time for today. And Renew, that was fun.
That was a great chat.
Yeah, it is. PSMA PET never fails to disappoint. And thank you very much, Dan, for coming in and joining us today.
It was a pleasure. Thanks, guys.
Fantastic. And that's all we've got time for here from myself and Renew. Lovely to chat to you all again. Please send us your comments, anything else you want us to talk about. We're always very happy to hear that, aren't we, Renew?
Absolutely.
Fantastic. We wish you all the very best. Thanks to Dan, thanks to Louise, thanks to Anwar, and we'll talk to you all again soon. Thank you.